So yes, thanks for the introduction, Wendy. And I am at the Centre for Health Services Research. On December 31, I stepped down from the director role, and I'm now working part-time. Um, just by way of background, the Centre for Online Health is a major component of the Centre for Health Services Research. The CHSR was established in 2017. I directed the Centre for Online Health from 2009 to 2017, and Anthony Smith has now been director since that time, but I was the director of the Centre for Health Services Research up till last year, so I apologise for all of that, but some people on the call probably wondering what on earth I do with my time. So mostly now I'm working in aged care informatics, digital health, and quality improvement activities related to mainly around the use of new technologies and information systems. So it's exciting, it's a good time, as Mark has said, and on the back of the Royal Commission there is a lot of investment in trying to improve aged care in Australia, and I'll refer to some of that as I talk. So I was asked to talk about research in virtual care and provide some kind of historical perspective. I think people think I must be getting old and I must know stuff from way back, and that's kind of half true. I've done a little bit of digging and can provide you with some interesting insights about how the world of telehealth in particular, but more broadly around the whole concept of virtual health has evolved in Australia. So I'll just go down. I've got the slide up, but there we go. So if you dig around, you'll find the first paper that refers to anything like virtual health or telemedicine or telehealth was this paper that was published in the Medical Journal of Australia by Peter Yellowlees back in 1993. I've kind of researched the telehealth literature more than the virtual health. Simply, the term virtual health didn't really appear much in the literature until the 2000s. But given telehealth is really a kind of a variation on the theme of virtual health, I thought it would be useful to look at the telehealth literature, and I know it pretty well. So this original paper was written by Peter Yellowlees when he was the chief psychiatrist in South Australia, and you can see from the first sentence that the big challenge in Australia was the fact that 30% of Australians don't live in metropolitan centres, and distance was a huge issue in terms of equitable distribution of healthcare. So that's been the driving paradigm for most of the evolution of telehealth in Australia, until perhaps the last 5 or 10 years, where many of us woke up that telehealth and virtual health were really probably as relevant, if not more relevant, in city-based practice for many of the reasons that we've heard discussed earlier this morning. So this is Peter Yellowlees. He was the initial director of the Centre for Online Health. He migrated from his role as chief psychiatrist in South Australia to the University of Queensland back in the mid-90s. And he and the then Dean of Medicine and Health Sciences, Peter Brooks, established the Centre for Online Health, and that was really the major research centre for virtual health, telehealth for quite some time. Peter migrated to the US to UC Davis in about the late 90s, and the role was then taken over by Richard Wooten, who remained in that role until about 2009 when I took over the role. So these were very influential folks in what was a fairly small area of activity in Australia, but really focusing on the problem of providing equitable access of healthcare, particularly consultation type services, into remote communities. So this is the Centre for Online Health website. It's got a lot of really interesting information about telehealth and virtual health, and it's well worth visiting. It's not just a marketing website, but it also is full of very useful information about what's happening in telehealth. There's some tool sets there for people that are interested in this kind of work. So I encourage you to have a look. So looking at telehealth publications, since 1995, in fact. You can see that it kind of grumbled along up till about 2014, and then there's been an explosion of activity. And if you profile if you use the search term virtual health, you get a similar kind of profile of activity, although at a much lower scale. So what really was happening was, and I use the term specialist researchers, but these during the period up to about 2014, most of the research output in terms of publications was by individuals like Peter Yellowlees and Richard Wooten, who were committed to the paradigm of remote care. And what's happened since then, we have really an era of folks that are not particularly, their primary line of research is not around virtual health or telehealth, but they're entering that paradigm from a specialist perspective. So they might be a dermatologist that realizes that dermatology would lend some aspect of dermatology would lend itself to some kind of virtual health or telehealth solution. So there's been a wonderful, if you like, broadening of interest in telehealth since about telehealth research since about 2014. Bearing in mind, as we heard just a moment ago, that funding of any substance for telehealth really didn't happen until 2011, when MBS item numbers for specialists providing care in rural communities was introduced. And I can tell you, I was involved in that process. There was a huge battle to get that in place for many years prior to 2011. Just for fun, yesterday I kind of sought out who were the leading publishers in telehealth in Australia, and this is the top 10 folks. And Richard Wooten, who was the director of the Centre for Online Health, leads the pack, although many of his publications were produced after he left Australia and went to Norway and the UK to work back in 2009. Anthony Smith is by far the most productive and still working telehealth publisher in Australia. Peter Yellowlees, again, many of his publications were generated out in California. Peter Sawyer is a dermatologist with a passionate interest in teledermatology. He's probably the world leader in teledermatology. Trevor Russell's a physiotherapist who also works at UQ and has promoted the use of telehealth and virtual health for allied health. And Helen Christensen, the only non-UQ person in the top 10, is at the University of New South Wales, and her work is very focused on use of virtual health for people with mental illness. And then myself, Liam Caffrey and Nigel Armfield also RANs in the top 10. But I'm not trying to promote UQ, but I am. It's been, if you think about the people that have been involved in production of research output for telehealth in Australia, indeed in the world, UQ has been a real leader. And if you do international searches, similar sorts of searches internationally for telehealth outputs, UQ's up there with the best universities in the world. I think it's the top ranking university for telehealth research. Others like Harvard and Calgary and also there in that kind of group. So we do have a strong kind of initiating presence in this kind of work here in Australia. We're very proud of this at UQ, of course. Enough of that. This is Anthony Smith. He'll hit the top of the pile sometime soon. He's kind of the Buddy Franklin of telehealth research in Australia. Whether he'll be mobbed when he gets to when he exceeds Richard Wooten's or gets to his 200th publication in telehealth, it remains to be seen. But Anthony's very active. He edits the Journal of Telehealth and Telecare in Australia, and he's done the journal proud over the last 5 years. So just turning more to thinking about telemedicine, telehealth, virtual health, I think the aspirations of these concepts are threefold. One is to improve access to care for folks that have got problems accessing due either to distance, but also be mindful that access is a problem for people with disability or who have disadvantaged socio-economic circumstances. Not easy to get to see people, and so the whole issue about access has really driven the development of telehealth in Australia. But of course, there's a kind of line of interest around the efficient delivery of healthcare. In other words, can some aspects of healthcare be delivered at a lower cost without prejudicing quality? And so that's a secondary aspiration. And the third one is some forms of telehealth, and there's reasonably good evidence in the literature around this now, that telemedicine virtual care is not a kind of poor man's version of real care. In some circumstances you get better outcomes, and this is particularly true in some mental health services and a whole lot of subsets of activities in various disciplines. So we don't think of it as a kind of poor man's version of real care. It's actually in many circumstances an augmentation of healthcare delivery, and virtual care, of course, follows the same kind of considerations. How can we get care to people at a distance? Can we make it less expensive? Can we actually do a better job if we use virtual care type approaches? Of course, my own view is that what the ideal is some kind of blended approach. So a blend of real interactions in person and, of course, using virtual health as a kind of augmentation of the existing traditional kind of approaches to healthcare. So, and of course, we talk about various kind of, there's a lot of terminology here that's kind of overlapping when we start talking about telehealth or virtual health. Digital health kind of creeps into the space. So when you start doing things like a literature search, you got to use multiple terms to find the kind of work that's relevant to this conversation. So we heard a little earlier that the MBS item numbers were introduced in 2011 for specialist care, but in fact psychiatry attracted, and this was Peter Yellerlee's advocacy way back. There have been item numbers on the MBS schedule since 2003 for psychiatry. And of course, the COVID imperative generated the introduction of item numbers, I think 2019, early 2020, for primary care. And as you heard, there was an explosion of use of virtual care or telehealth as a result of COVID. Interestingly, in my time, and Anthony and I, and a whole group of us had been advocating for the availability of payment methods for teleconsultations well before 2019, and the government and Medicare were really reticent because of this issue that's still a live issue about whether they're funding a substitution for real in-person consultations, or it's simply paying for a lot of the telephone work that was normally done at no cost or with no remuneration. And we basically believe that there is a whole school of thought that thinks the telephone component should be funded anyway. And that gets to the whole discussion about paying for people's time through fee-for-service. It gets a bit messy when you try to reduce everything to little events. I picked up the phone talk for 2 minutes, that's $10. This kind of thing is, it gets ridiculous and the paperwork out of control. And that's a fundamental problem of the MBS approach to funding healthcare. As many of you know, it's got its strengths, it's got its weaknesses. On the other hand, hospital care has not been uniformly supported in any way, and it's still a patchy kind of set of arrangements. I'm working in Queensland. To the credit of the Queensland health people, they began to provide fee-for-service or activity-based funding for telehealth about 2012. It might have been a little bit later, but that resulted in quite a dramatic increase in activity out of hospitals into rural communities, and that continues to today, although was largely configured as incentive funding to get hospitals to start providing telehealth services. Some other states have followed with varying degrees of generosity in terms of how much funding and what kind of events are supported. And of course, then some hospitals and some providers have started to work out ways to support remote monitoring as a component of healthcare, although, as you all know, that how to support remote monitoring in the current service configuration that we have in Australia is quite problematic, and that differentiates it from other environments. I'll talk a little bit more about that in a minute. This is just a snapshot. I think it's reinforcing some of the commentary we heard earlier, but interestingly, even in quarter 4 2021, which is the last set of data that we have, there were some 12 million telehealth consultations in the quarter, representing 25% of all interactions. And prior to COVID, the number was less than 1%. So that's been a massively different escalation of telehealth activity. Now, of course, you probably know, most of it's use of the telephone. And again, those of us in research, those of us in administration were raising the question about whether this was a material improvement in the way healthcare delivered. Is this investment in telephone communication producing better health outcomes, or is it simply paying doctors more to do what they were doing before? And that remains a really important research question, and something that we're doing some work on, but many others will be addressing that, in the government not least of all. This is another image from the COH website, which really presents the by quarter the real and telehealth consultation. So in quarter 2 2020, after telehealth became a funded opportunity for GPs and more broadly for specialists, you can see that there was a massive increase in the number of telephone interactions. Interestingly, by about quarter 2 2021, we were thinking, well, this is all going to go away gradually, but in fact, it does look like it's stabilizing at around about 25% of activity. And also, you'll note that video conferencing, the orange bars, but virtually not video conferencing, but you can see that there is a kind of increasing use of video conferences. A whole lot of big discussion about why that's happening. I'm sure there are multiple reasons. And Medicare at the moment is contemplating and working on incentivizing video conferencing over telephone, and I'm sure there are lots of decisions to be made about that in the near future. So just a word about where we're at with remote monitoring. This activity's been around for a long time. I think Mark talked about it a little bit earlier. There are certain things you can monitor and certain things you can't monitor, and it's particularly in aged care. Interest in biological markers kind of a bit boring to me. I've got to say, I'm not that interested in what the pulse rate is in an older person unless they're acutely ill, but otherwise it's kind of interesting but not particularly helpful when their care needs are often related to their cognitive impairment or or mobility and so forth. So there's a lot of work to be done to make this a richer kind of opportunity, but nonetheless, there are many patient groups where, particularly those with cardiovascular, respiratory problems, diabetes and so forth, where it's a very important potential augmentation of care. So the problem here, and this is just my perspective, is that the provider arrangements, folks, with these problems is highly fragmented. So, we do a lot of work with diabetics. They come to the outpatient clinic. They see a GP. Their funding comes from multiple sources. They try to provide a kind of infrastructure to support their diabetes care. And by the way, they've also got cardiovascular disease and other problems. Who's providing the infrastructure that provides comprehensive care? It really is messy. So when you try to bring things like remote monitoring, virtual care in, the problem's not necessarily with the systems, it's who's funding the systems and who's coordinating them that becomes the problem. So yes, different stakeholders have different interests. So hospitals, generally fund or are interested in, for that matter, state governments in keeping people out of hospital. That's not necessarily the aspiration of other providers who want people to feel good and to manage their illness, and the hospital piece of it is relatively minor. Again, this kind of work is fragmented, hard to set systems up that have economies of scale, and this is in contrast to other countries like the VA in the US has massive scale in terms of use of remote monitoring, so it gets the price down and it becomes part of the standard of care there. We have such a fragmented system here, it's hard to get those economies of scale. The lack of integration with information systems, again, Mark talked about that. This is, in my mind, a really critical problem in all virtual care, is providing comprehensive and integrated information. Stop repeating the story, but more importantly, just knowing what's happened before and basically being able to access that. Doctors are so unfamiliar with using readily available information because it's not there. They basically, every time see a patient, they start the story again. Please tell me what your problem is. And so you get repetition of the history. And it's so ingrained into medical practice now, it's hard to stop. And even when you do provide information, I see my colleagues continuing to do it in the old paradigm. And then there's the evidence around the cost effectiveness of remote monitoring is pretty marginal. There's not really powerful information here. I think really probably it's not a cost saver, but it probably is a valuable, in certain circumstances, use. But of course the price comes down when you get economies of scale, so that changes the whole paradigm if you can get it set up correctly. And then of course I've alluded to the fact that that someone's got to work out who's going to pay, and that's a huge challenge. And so that you can see there's a whole bunch of research questions that need to be addressed around this. I draw your attention to a paper that one of our junior postdocs has written along with some of my colleagues around thinking about what happens, what should happen on the back of this COVID-19 investment in telehealth. And Emma's provided a very helpful discussion about the parameters that need to be worked on. You see development of a skilled workforce, empowering tumours, reforming the funding arrangements, digital ecosystems, etc. It's a good read, and it's in the Journal of Telemedicine and Telecare. Now, just say a little bit in the last few minutes about economic benefits. Governments in particular, payers, like to see projects or initiatives that sit into that green box where the cost is reduced and the clinical benefits are enhanced, and that's kind of what we all hope for. And you certainly don't want to invest in initiatives that increase the cost and reduce the benefit. But it's not entirely true. What about, what we hear about particularly in remote or for disabled people, is that you can get a less clinical benefit at a higher cost, but you get something. You don't get nothing, because a lot of these folks don't get any care. So sometimes the economic solution may be that you have to pay a bit more and it doesn't work quite as well, but it's a hell of a lot better than nothing. And so that's a constant conversation I have with folks who want to see, improve cost, reduce cost and better clinical benefit. I'm just suggesting we have to think about this using the access paradigm as well, and that then provides another dimension to the whole cost-benefit equation. I just feel that's a really important point that we mustn't forget. I wanted to just mention that my work, this is Aged Care Data Compare, it kind of is trying to fix the problem of data standardization in aged care. It's not just residential care. And we're using the HL7 fire messaging technology. We're building a whole kind of solution that will enable granular data, that is individual data elements, to be passed around the health system, as well as whole assessments to be shared amongst providers. And that means smooth transition of data from residential aged care to hospitals and so forth. And that work is going well, and it's well supported by the Australian Government and the Digital Health Cooperative Research Centre. So just a little draw your attention to the fact that there is quite a bit of work now happening around the data infrastructure problem that's so important for virtual health. And finally, I just wanted to, here's just a kind of potpourri of things that I think we as researchers need to think about in the next little while. So, what's the best balance? And this will obviously be relevant to whatever problems a person has, but for each type of condition, each type of individual, how do you get the right blend, and how do you incentivize that blend of in-person and virtual interactions? The big issue, it's been going on for a long time, unfortunately, is how in the Australian environment can we produce an integrated solution for delivery of healthcare, and what are the policy adjustments? And this is pretty depressing, really. Attempts to kind of integrate state and federal based healthcare delivery has basically been a failure, and that's a huge problem for all of us who are looking after folks that have got complex ongoing problems. What other incentives could be put in place? The government has tended to put incentive payments into systems and then kind of withdraw them gradually. Is there still a place for this in virtual health? What can we do about remote monitoring in the current delivery? How can we make it work in Australia, in other words? What do we really need to do to the health system to support this kind of care? Because that's the right way to think about it. And of course, we need to be constantly thinking about patients, how they experience all of this, bearing in mind that the patients' attitudes change as they expose to this kind of thing. Reticence turns to positivity with, in many instances, where there is exposure to a virtual solution. So I think that's all I have to say. It's been a great opportunity to kind of reflect on the past a little bit and to pose to you some questions for future research in virtual care. So thank you very much.